it doesn't truly happen.
Exactly.
For some reason, you know, because they haven't really, because Susan was always closing.
Good.
Now I got paid 582,000.
That was my old.
Think about it. Ashley. Ashley.
Yeah, and I don't want to get this.
Now I got paid 582,000.
Yes. How it is, yeah. Really?
All right, team, it's right at 3 o'clock. Let's go ahead and get started. It's good to see everyone. And whoever has the first
Thank you,
slide.
everybody, for coming. Our quarterly meeting with the health center update, and our advisors are here to give us their presentation on how we're doing.
We always kind of let Dr. Pace give any opening comments, if you'd like to, before we get started.
And turn it over to the team.
So the first
We're looking at
part,
this one, not this one, right?
yes. The first part of our presentation is from Kenneth on the Health Center, starting on page 4. We're going to reference a different page.
No. We're going to start on page 4. Welcome to the new board members. So the first couple of pages are really focused on the health center, looking at trends, utilization. We're going to move over that because I really want to get to the outcomes and some of the great things that we're going to be bringing to the health center for more prevention and screening and opportunities to find some of the things that might be lingering out there. So the first, again, page 4 is really just about utilization on some of the different line items, and then just on no-shows and cancellations, and then unique members. Slide 5 is specific to Poinciana for the utilization of that facility. That facility right now, we're only there 2 part-time half-days because we're partnered with a specialty group so that we can use their facility and keep costs down. But we're looking at putting in some strategies for expanding some other facilities just based on the expansiveness of this county. Oh, yeah. This is where we dive into just trending of the entire population, looking at what
Slide
services
6.
they received on slide 6. And then also, how has that utilization been over a period of time? Breaking it down into the different type of, is it an urgent care visit, is it a new visit, those type of things. But those are the level of details just that you can look over, and if you have any questions, you can ask me about those. Same with the next slide. Slide 7 is about more on the physical therapy. The nice thing about the physical therapy, we saw an increase on some of the new patient visits. We anticipate that we're going to increase on the physical therapy portion just because we had to stop workers' comp for a period of time. Yet we now have workers' comp providers. One of our workers' comp providers, her husband got promoted and had to move to St. Augustine. Now that we have those workers' comp providers, they're going to be referring back to our physical therapy department and our chiropractors within the facility.
So sorry, question about slide 6. Can you tell me what med EST is? the highest visits?
Med
Med,
established.
EST, that's established, those are patients.
So they're established
Yeah.
patients?
They've been there before. So med new would be a new patient.
Okay. What is Med 60?
That's a 60-minute visit, those are more complex type of visits. And then there's the med new would be those people who are brand new. Med urgent care, those are individuals who came in on a urgent need. Now, we don't do walk-ins,
Okay.
but if a patient calls us and we can fit them in, we do have appointments throughout the day that we'll fill, and we call it same day.
Yeah.
You know, we're not looking to be an urgent care facility where people just walk in and sit and wait for us. But those are those appointments that were not really set as an appointment, but they were brought in that same day.
Thank you.
Now, when you break it down that way, because you get reimbursed from that, like if you're charging an insurance company, we just tracking it that way and we're not charging anyone for those visits?
No, the district is paying for the health center,
Yeah.
and so
But I'm
we're
talking
not
about
sure-
normally when you create a super bill,
Mhm.
and, somebody sees an office visits for the new time, they track it that way because they're gonna get paid, reimbursed differently.
Correct.
Like the amount of reimbursement for new visits is different than a wellness visit. And I noticed that it's structured the same way, but is it just because that's the common practice? Because
No.
we're not billing anyone. I just wanna make sure that we're not billing one per
No.
visit. I thought we're supposed to just pay
We are.
staff full-time.
Correct.
No matter how many times they see it. So it really doesn't matter if it's I guess you want to know new visits because you want to see if somebody's new.
Yeah, so we do it that way, so we know, okay, who's new, who's established, and we can break it down based off of those, but then we can also look at, on the previous pages, you can see who's been, during that time period, who is there between 1 and 2 visits, all the way up to 6+ visits. So it really just gives us a picture during that period of
But
time.
nobody's billing Medicaid or getting
No.
reimbursed or getting
No.
paid for anything like
Nope.
that. So-
No, there's no extra billing that is done. It's more for tracking purposes,
Okay.
for just the reporting for our facility.
And that makes sense if it's structured that way. I just want to make sure.
No, good question. Let's see.
Just finished
Page
on
eight.
PT.
Yeah, so page 8 is more on the workers' comp. You'll see those numbers increase, which is page 8, as we have our new workers' comp providers, and then be able to keep all that in-house to save money for the district, and also try and contain it within the facility, not only just for the medical piece, but also our chiropractor can provide workers' comp and save you money, but also same with our physical therapists can save the district money by providing it in-house.
Looks like the activity has been diminishing.
Yeah, and that's because we lost our workers' comp provider.
That'll do it.
That will do it.
Data, it's crazy. Do you know what the delta is? The difference between, like, how much are we saving by keeping it in-house versus referring out workers' comp specifically?
I do not know the number, but we can get it.
Yeah, I mean, I'm glad we're saving
We did it based
money.
on just the health center appointments to the outside last year, and we could do an analysis on the workers' comp.
And when did we switch over? Is it February 2022?
Switch over for the
Like
health
from,
center.
yeah, no, the workers' comp portion.
Oh, yeah,
When
it was
did
in-
when did the,
We started in 19, I think we started in 2020.
We started in 2020 and then.
oh, a
we
long
had-
time ago. I thought it was
Yeah, we've
recent.
had several instances where we lost a provider, so it hasn't been a full year consistently. It's been a year, but a year and
The
there.
providers that work in workers' compensation it's an area of specialty, so it's just not a regular family medicine doctor. They have to have training in workers' compensation claims.
Physical
DOT
medicine.
physical.
Correct.
And why are they changing so much? Why is there turnover?
So, I kind of mentioned that our provider had moved away. Her husband got a different job, so she had been there a while.
And then it took us a while to find her replacement, and then she asked for a change in schedule, so we lost her basically as well to 1 day a week. We couldn't do that for our workers' comp, but now we have two
Two.
that are starting.
Two very strong ones
Yes.
that we'll be able to really contain our cost.
But when you do that comparison, even if you came up with, it's costing us the same amount to do it here, even if you
Yeah.
came up with that, there's more to it than just that cost, right? Because we better control it, Work comp is kind of hard to control patients and that sort of thing, and if you're doing it here, you have more control.
Right, so is a provider like being paid like a full-time salary, or are they considered like a firm, or are they just considered, like, who are they an employee of?
Full-time employee, full-time salary is what they will be earning.
And they're gonna be full-time dedicated to our site, or are they
Yes.
rotating a couple different sites?
No, your site.
And their schedules are based on our hours. So one will come in at 7, the other one stays till 7, so we always have provider coverage.
And then same with our radiology techs that you had met. We do have that coverage so that we can provide that coverage throughout the day. So we were on slide 9. There is more like the occupational, but also the chiropractic visits for the facility. You see those numbers have continued to increase for the population. And in some of this data that you have over here in this binder, you'll see, some of the top diagnoses are going to be your back pains and things like that. So it's really good that we've contained it and brought it in-house with the physical therapist and with our chiropractor. Yeah, slide 10, 4.90 is what we've scored out of 5. The good news is November, we actually hit 4.91. And you see how many surveys are actually conducted, and those surveys are actually sent to the member, the patient, after each visit to the facility. And they have the opportunity to actually score us and also make comments on, hey, anything that they would like to see. We actually had one member who commented that she'd love to see massage therapy in our facility. Not necessarily something we'd want to do, but at least it was a nice comment to place in there. Okay, this is the fun stuff. This is the stuff on page 11. This is areas looking at really the chronic care conditions, your hypertensives, your diabetics, your asthmatics, those type of things. We've captured more of the population. So when you're looking at your overall health spend, your spend is going to be basically your chronic care conditions. 75 to 85% of that's going to be those individuals. And over time, your health center has captured more and more of those individuals, such as we're at 65% of the diabetics are coming to your facility, and same with the hypertensives. And now the asthmatics, we're at 61.6%, which I'm very pleased about. Some of the metrics in here that you see talks about how we've improved either on the diabetic population, or we've reduced the number of ER visits over that period of time. On slide 12, you'll see some of those. And now these numbers are specific to the health center. These are health center users. So when we're looking at how many ER visits do we reduce, or how many colorectal cancer screenings we've done, it's for that population specifically versus the entire population. So on slide 16, no, that's not 16, sorry.
Christians.
Yeah.
You want the,
Utilization.
so you have 2 slides. You have
Yeah, this one.
slide 12.
So on here, you see, one of the things that one of the previous board members were talking to us about was the mammograms. That's the W08 on slide 12. And you see for your health center population, we're at an 85% compliance, and that's spectacular. I'm happy.
That's up 30% from last year.
Yeah, last period we were at 77, now we're at 85, which is for the health center. That's really good. I'm pleased with that number. The colorectal cancer at the very bottom, cancer screening, you see we're at 76%. I'm going to segue in that piece because everybody else would be jumping for joy at that number relative to the population, but we're not. We're not going to just settle in. Because on the next slide, on 13, you're going to see, what have we done? So when we came in, we recognized that the population wasn't getting it done, wasn't getting colorectal cancer screening done. And if we can catch it early, there's a better chance of survivability, number one. And number two, lower cost for you as a district. So we were able to get approved by your team to bring in Cologuard. And Cologuard is something that we contracted at Rosen, and we were able to bring that contract over here to the district. Good. But not good enough. You see that number on here, we're at a 68% return rate, say 70%. Again, everybody would be jumping for joy saying, hey, great job, everybody's doing great, but we still have 30% out there that are not returning the test. The best test is going to be the one that the patient does. So we've gotten approval. We're moving forward with, the next slide, please. What is called...
I want to talk about the one.
Oh, yeah.
Yeah,
So back to that 30%, sorry, who haven't returned it, your population has a positivity rate, meaning a positivity of a Cologuard of 10.6%. So let's break it down into 100 people. So if 100 people were tested or given the test, 70% 70 of them return it. That means 30 people haven't done it, and 10%, so 3 individuals, 3 of your members, 3 of your teachers or employees might have colon cancer. So that's where we're now moving into, okay, let's take it the next step. And that next step is going to be a blood test. And that blood test.
It's important to point out the Cologuard is a stool sample,
Yes.
correct?
Yeah.
Which is unpleasant, but, and could be part of the cause for people not following up on the test.
Yeah,
So
that
hence the
could be.
blood test.
And so the blood test, we'll be able to do it at your health center. Now, we're going to, as the healthcare team knows, first and foremost are the colonoscopy. Second will be the Cologuard. And lastly, we'll do the blood. Because it's easier for us to do, but it's going to cost more to the district. So we're going to try every route first before we go to that, because it's going to cost the district about $100 per test more than the Cologuard. Okay?
And when the Cologuard and the blood test, if it returns back a positive, you then need a colonoscopy.
Anyways,
So had you just done a colonoscopy, then you just would have done one done,
So
and you're done.
Garden is not, you won't ever do garden on somebody who has already done the Cologuard.
Correct.
So you're down to the 38%.
Nor anyone who had any previous history.
Right.
yeah, the
of-
history, if you're high risk, it's not prudent to do those tests.
So who are you targeting for the colon cancer test in general?
45 years up and older.
45 and up. Okay, so anybody who comes to our clinic who's 45 and up, we're recommending they get Cologuard.
We're
Any
recommending to
school-
get a colorectal cancer screening.
And, okay, great. And who's choosing is the patient choosing? I would like to do this versus this versus this?
It's
Or is it a
really-
recommendation?
It is a recommendation. I mean, the
Okay.
first thing that's going to come out of our mouths is, you're 45 years old, let's go ahead and do a colonoscopy. Now, I'm too busy, I don't want to do the test, there's patients who flat out say, I'm not going to do anything. And so those are the individuals that will coach and counsel and try and get them to, hey, we'll at least do the Cologuard. No, I'm not going to do that because it's disgusting or whatever it might be. Then we'll take it to the blood test.
But the Cologuard and the Guardian is not available if there's certain conditions. If someone has symptoms of something colon-related, they cannot do that.
Or history.
Or history, they have to go straight to colonoscopy.
Okay.
So the
this is
provider
like
would
the
then,
least invasive version of the colonoscopy?
Yes.
Okay.
but if it comes back positive, they have to then go have a colonoscopy done.
Yeah, I'm asking because I'm wondering, like,
The state-
how much are we actually saving if we have to go through, like, all of these steps? 1, 2, then we also have, like, 30% who's not doing it, so who knows, like, what that's, what the results of that is, and then the return rate. It's not terrible, but it's also, so, like, with all of those inputs in mind, like, how effective really is it just to say, do this versus you're here, can we do a blood test, which you've stated that it's more effective.
No, it's the same.
It's the same effectiveness.
Yeah, it's just easier.
But it costs more money, and if it comes back positive, you then go back to step number 1. So the best one is, ultimately, is the colonoscopy, because if it comes back positive, you've already been there.
Yeah.
If they don't want to go under and have all that prep work, because there's a lot of work involved with it, then we do the
Yeah,
Cologuard.
I mean,
or
ultimately,
the
we're
blood
going to
work.
leave it to the provider, patient, you have the relationship, and, hey, as long as they say they've done everything and they do it, okay, fine.
Yeah.
Let's just get it done. That's the ultimate goal.
Now, your approach to this will change, I would presume, under the new health plan that is health center centric.
No, I don't think, no, it won't
Guidelines.
change, it's going to be the same guidelines.
But you'll be the providing physician as well.
Yeah, I mean, even in our cases, it's still that patient-physician
It's
relationship.
important to know
so-
that of the 70%, we only pay for that test when it's sent in. So the kit is, the person receives the kit at home. We don't pay for that processing until they return it. So it's sitting there in the closet somewhere, or in the garage, or in the back of the trunk.
Or in the trash.
But we pay for it when it's processed.
Okay.
But our team is following up on
Yeah.
those 30, or that 30%, Hey,
Because we
haven't
know
you
that they
done
haven't
it?
returned it yet.
Yeah.
Why haven't you done it?
Ultimate savings is just early prevention.
Yes.
And quality of life.
Yeah, I mean, if we can find it early, the survivability rate is in the double digits, like 80-something%. But if we don't find it early enough, we're talking single digits.
And you hear about it all the time. It's getting younger and younger.
Yeah.
So the guidelines just moved from 50 to 45 2 years ago or so. So definitely we charge 45, it's on their trigger of, we need to have it done.
So again, just
On
to
a
keep.
side note though,
Huh?
just before I forget, because the mammograms, what do we do different? Because I remember we had the same conversation about about color guard for mammograms. We're like, do we get a bus out there? We were like experimenting with different things.
We
Just
tried
out of
both.
curiosity, what was it that was resonating the most? That got them?
So the bus didn't resonate with the teachers or with the population, and we had a lot that were not showing up, not canceling, and that's a service, that vendor is paying to have the team out there and the bus out there. So the population's getting it done, they're going out into the general community, so wherever they're gonna get it done, as long as they get it done, it doesn't matter to me.
Because there's no mammography on the clinical site.
No.
They have to actually get a referral to go somewhere else. It's like.
A prescription.
Not yet.
What'd you say? Yes?
He asked, is it on site?
Yeah.
Not yet.
And it also was timing. A lot of our employees, they're off in the summer, so they'll get everything done in the summertime.
And that's what we did express with the data. We said, hey, let's just see, because it's typically in the summer.
So we just do a big recruitment push when the summertime comes, instead of forcing it throughout the whole year and spending effort,
Just do big
resources.
reminders.
Just do a big reminder at the end of the year. Hey, it's the end of the year. If you haven't had your mammogram, if you're within that age population, like promote it during the time it's like the peak season, so to speak.
Yep, absolutely. The next exciting piece, again, on the prevention standpoint, we live in Florida, and melanoma and skin cancer is, it is something that we need to be looking for. Doesn't matter if you're
Slide 16.
white or black, we're going to get it done. So we've, at Rosen, we've launched our program called, it's not our program, but we've launched with a vendor partner called OnSpot Dermatology. They're going to be coming to your facility, to the health center, and we're going to be doing skin screenings at the facility. The bus has a dermatologist on board, and they can do advanced surgeries on it. We've already had 2 events over at the Rosen, and now we're bringing it over to the district to get that skin screening done. Very nice, quick, easy. It'll be run through the health center. We'll do all the scheduling through the health center, so then we can catch any kind of no-shows or late cancellations, so we can follow up with the population.
I think once you get a handle on your current population, using something like this could be a draw to those people who have not visited the health center. Because it's impossible to get in to see a dermatologist.
Yes.
How often is this going to be on site?
Yep, it's going to be to start once a month, and as we see the demand and we see the uptake, then we're going to start bringing it even more. We do have the bus scheduled to attend the
Okay.
P- yeah, I always get it right. The 5K. So they're going to be there with all of us, and all our staff will be there too,
So they'll
to
be seeing patients that day.
seeing patients that day.
And showing them how it looks. So we had it at our office on Thursday, so I did myself.
I haven't.
And it was a very pleasant, I was in and out in half an hour, between checking in, derobing, having them examine. I mean, they know exactly what they're looking for.
Yeah.
And, I mean, I had something removed, thing that, and on my way out. So it was pretty simple.
So we're starting off, again, it's another opportunity, just like Barry said, of drawing individuals to the center to recognize what other things that we do have there. We're going to do the skin screening, but if there's a problem, or if a person has, some sort of dermatosis or something,
Eczema or something.
it's going to be a referral. We're going to treat it as a referral, so that the teacher or the patient can use that facility for that diagnosis and not just a skin screening. So we're working through the implementation process now to make sure we get it to your facility and then make it
The
successful.
only concern is sometimes we're introducing too many things at once. Like when we said, hey, let's try to get a handle on the mammograms. Then it's like, hey, the chiropractors are doing chiropractor. Now we're doing ophthalmology. Now we're doing this and that. And it's like, man, we're introducing a lot of stuff. And sometimes it's kind of hard to get full implementation of something when you're changing 10 things at one time.
Yeah, so on,
Now, is there a response? Like, is there a high, skin cancer rate? Like, hey, now let's focus our efforts and let's bring a dermatologist. I'm trying to say, now we're doing workers' comp. You know what I'm trying to say? I feel like sometimes it's cool, and trust me, I got ADD, so we're talking the same language. But sometimes I gotta discipline myself and say, okay, look, let's kill something completely. You know what I'm saying? Let's get a handle on it before we come up with all these new initiatives, because it doesn't look free. And that's like adding costs onto us. You know what I'm saying? Without fully knocking out another project. You know what I mean? And that's just my concern. I'm just
We're
wondering.
seeing
you're
a gap,
absolutely-
there's a gap in care. So all the reports that we have are showing the members aren't doing it. And so, and especially here in Florida, skin cancer is prevalent. So if they're not getting it done, we want to make it easily accessible to them so they can get it done. So again, their quality of life down the line, melanoma developing, it's something that's so simple. It's not like mammograms, probably never had one, but it's not the most pleasant experience in the world. This is not, it's not difficult at all. And we can get a lot of people through at one time.
No, but you're absolutely right. I mean, with the chiropractic, we did the uptake on that. The colorectal cancer is not going to be anything that we have to market. It's just the awareness from our provider standpoint. So there's no engagement that needs to be done except for just the regular colorectal cancer screening awareness that we're already doing. This, Mr. Melendez, if you turn to page 19, you'll see some of the outcomes from the population. And look at that, 129 melanomas. And going through school.
And those
I
are
mean-
our employees.
No, these are not, we haven't launched your program yet. This is just from the general population in the Central Florida area.
Since 2001.
Yeah, so 2021. So even though that number relative to the total population, but just one melanoma that we can find, early treat, and save that person's life. We had, the reason why, we were focused on that, in the Rosen population, in my career there, we had 3 people pass away from melanoma.
My goodness.
3. And we were doing everything like the traditional, go to the dermatologist, go to the dermatologist, go to the dermatologist. Now we're bringing it to the members. And we bring it to the members, we can do it on board, we can do the screen, the biopsies, and advanced surgery on the bus. That's going to be a game changer. And I'm praying that we find something, because we find it, but I'm also praying we don't find something, both sides of it.
I think it's important at the board level for you to recognize that this is an investment. And it does, or it will tend to cause the cost for the health center to increase as you add value and services. And again, going back to that hackneyed little bucket, big bucket, hopefully the investment in access to screening prevents some bigger claims down the road.
And what's the cost associated with it, too? That's the other thing I didn't even think about, too.
So yeah, this is public record, so I can tell you the
Because when you introduce a new idea, it's always good
It's a
practice to
proclaim cost.
say
It is a
how much it
proclaim,
costs.
and it's south of Medicare, is what I can tell you.
Yeah. And just in the future, again, it's the rest of the board, they can choose to do what they want. But, because right now, we're looking at, the CFO had a conversation that we may have to subsidize healthcare fund. So like, whoa, so now we're like talking about just subsidizing it. Now to subsidize it and adding more programs and adding layers, at some point, we have to have a cost to benefit ratio analysis and make that determination of, how much, because we don't have an unlimited pot of money.
Absolutely. And each time that I.
And I'm not saying it's not important. Maybe we kind of prioritize it as a board. Maybe we have our strategic workshop and say, okay, we have X number of dollars. What are the top 3 things that we want to focus on first?
Right.
Before just,
I think with healthcare, it's more about like what benefits, yes, what benefits our, bottom line, because that is ultimately what we five are charged for, but also remember that healthcare, especially in this county and this country, is like a recruiting tool. So we want to have the best that we can provide, even if it's maybe a little bit more costly, because that ultimately helps us with some of the additional ancillary issues, for example, teacher shortage, right? So I do think it's like we have to have both of those conversations in tandem. I don't want to focus so much on like, is this like much more expensive versus is this providing a benefit to our population that they otherwise wouldn't have? Is that going to be the difference between them going to Orange, Polk, or Osceola? Like, bigger picture for me is what I think about.
yeah, because I feel like we just got hit with this.
Oh,
and
sure.
I just want to have like a plan, because right now, it's like, even though it may only cost $5 more a month,
Yeah.
right now, the teachers are hurting, $5 here, $2 there, you know what I mean? It's like, and when you actually put it per plan.
Yeah.
Preventive care, hundreds of them will be less than taking care of one person with melanoma.
Worse.
So, right now, we'll go over into the data, when Barry will go over the data, is that the population needs medical care.
But the
Yeah.
point is to have like a strategic discussion, because
Yeah.
today it's this, I didn't see it, then tomorrow it might be whatever, the next thing you know, we have a kaleidoscope of everything, and that's good, but sometimes you can't be everything to everybody, sometimes, because again, it's a financial constraint, you know what I mean? If I didn't have to, if the CFO didn't tell me we have to possibly put in $6 million into the pot, then yeah, spend But Lord,
for
we're gonna have to
dermatology,
probably put in,
it's
I mean, is that,
an
let me,
NMA.
before I make something, I'm looking at my CFO, right? Is that, there is?
You're making sense, but I think you have to look at this as an investment.
No, no, I understand investment. No, I'm just about,
And
is
it's
there a
not
fact
just
that,
that
that
you're
you're gonna be asking the board to
subsidizing.
put some money into the healthcare trust?
Yes,
fund?
but keep in mind, the board already pays 80-something% of the entire healthcare costs. So it's not like you're subsidizing an additional amount. The
Okay.
board does cover the cost of healthcare, the majority of the cost of healthcare for all of our employees. It's north of 80%, so.
And the goal behind some of these services is, as Carolyn said, preventative health. Because if we can keep people healthier in the long run, they're going to have fewer medical costs incurred at a high level. And it increases things like productivity, job attendance, as well as then seen as a benefit in recruitment and care.
Yeah.
But the most important thing is to prevent that big expense of caring for someone with melanoma that's gone untreated and that often ends in death, and keeping them healthy and at work.
And again, and I understand the whole idea of the prevention, but like, for instance, we had an issue with diabetes being high. We have a problem with something now. As a board member, I like to say, you know what, let's get more compliance with diabetes and knock that out. You know what I'm trying to say? It's just the whole point of having a strategic vision, because we could try to prevent everything. We can think of, I can come up with a list of diagnoses of everything that exists. Maybe, post-traumatic stress disorder because of dealing with our kids in school. You know what I mean? It's like, and we could try to have, psychologists and reinvest and say there's savings and everything. But at the same time, that's why we have information. That's why we have consultants telling us this is what currently exists. I want to knock out what currently exists first, knock that down to the minimus factor before we try to play prevention on something that could possibly occur if nobody has it in the district. Now, if you told me there's 129 melanoma cases in our school district,
We wouldn't
then
know though.
we need to jump in.
Because we
You
don't
don't know,
know.
because no one's had to.
No, I get it, but the problem, what I do know is I only have a certain amount of money to spend. That's what I'm saying. You're spending my money, well, the taxpayer money, you're spending, well, technically mine, like, it's the board's money, but whatever, it's the tax, but you're spending my money to figure that out, and it's so cute to do that. But to me, I pretend like it's my cash. I'm like, ooh, every time I spend the money out, I just want to be strategic about it. I'm not saying that this can't happen, but let's just, I'm trying to say, because then you try to prevent so much, and you try to do everything, and you don't fix anything. You know what I'm saying?
I'm listening to what you're saying, into what you're saying about the breast cancer testing to see, yeah, we did the bus, well, folks weren't using it, so let's not go there next, let's do something different. And I do think that the data is important to always stay on top of, to take a look at the trends, if maybe they weren't aware of it, or maybe it's the hours it's offered, or whatever the services might be, what the barrier might be, but having that fluent data constantly is very important to take a look at, which is back to strategy too, so.
And you have a diverse population. So it's, mammograms don't apply to half the population. So, things that PSA tests and things like that too, so,
Absolutely.
yeah,
Save lives.
yes.
Page 21. And everybody, I think, except for the two new board members, has seen this dashboard. I think. Oh, you have,
I have
okay.
seen this.
Oh, well, discussing it. So, just a lot of numbers on here. What we tend to focus on, we think is the most important number. If you go down about halfway in this big chart in the upper left-hand corner, it says PEPM total expenses. That's per employee per month total expenses. You will see that when we, back in 2018, it was 811. Went down to 761, went down to 701, and it's back to 812. So it's roughly in line with where you were back in 2018, which is, in the healthcare world, you rarely ever see anything like that. Usually it would be a lot more. So the 812 is roughly about, it's suggesting that had you not moved to this new way of doing things, you would be paying about $15 million more than you are.
How does this data, how does what we're looking at relate to what you just said, to the outcome you just said?
So the actuary okay, is the one who had mentioned that the 812, okay, when you look at the time value, so going from the 811, based on your past experience, there's been a 6%
Got it.
inflation factor.
Thank you. Okay.
So, yeah, typically when you look at the 812 being more than 811, you go,
No,
whoa,
I
we're
figured
spending-
that, because I
yeah.
mean, time has passed, right? But like,
Yeah.
I just wanted to know what was the mechanism for figuring
Yeah.
out $15 million cost savings.
Yeah. And if you'll go to the next page,
And just so I'm interpreting
Yeah.
it correctly, now we're back up to above it now, right? In the last column.
Yes.
It's 812, so we're above where we were in 2018.
right, but a great place to be, right?
But really, you know,
Because-
if you're looking
Because
at,
of the time value of
Time value of money.
inflation.
we had a larger population at that
Correct.
time.
You would be, I think the number, I'd have to go back and look, but I think the number, you'd be right at about 965 had you not changed anything. So you're at, 812 versus the 965.
And it's important to notice the number right above that is the enrollment. And you can see that the enrollment is going down each year.
But if you look at the medical, it's gone from 584 to 559. The RX has gone from 156 to 121. And as we mentioned about, again, we keep revisiting it, but big bucket, little bucket, but we've had a bigger investment in the health center from 38 to 74.
Now, why is enrollment going down when our employee population has been going up? That's like going in the opposite direction.
We need to check this number because mine is not my average.
That was 70, the enrollment under the next slide, Lauren, 74,252 divided by 12.
Yeah, you know what I'm saying? Because back in 2018, for some of the new members, we're at 6,500. We built a couple schools since then, and so we definitely have more employees, you know what I mean? And yet, we have lower enrollment.
Yeah, that was the average, right, based on 12 months. But you can see it on the following page, you're right, it does climb from beginning of the year at 6,153 and goes all the way up to 6,433. Is that,
Was this a
Make more
snapshot?
sense?
Yeah,
You're on a
so this is
different
Yeah.
October.
yeah, it's just 74,000 divided by 12 that got us to the,
At the page 22, when we add up each month, we take the 74,252, then divide by 12.
Okay, so the average is down, but the actual number of folks enrolled is up?
Yes, 6433 as of September.
we can go back and look
No,
at
in August.
I understand why he's confused though, and I feel like
Well, of
if we're gonna talk to folks about this, we need to get a little nerdy.
Well-
So I get why he's confused, because I know this is an average, which can be lower than actual, but tell me why, I guess I'll start there. Why are we using average medical enrollment as a data point?
Well, we use the actual enrollment when we're doing the monthlies.
Yeah.
But when we do an annual recap, we have
Okay.
to use some average.
Yeah, so what you were saying is that when you took this snapshot, which was from 10/1/21 to 9/30/21, the average number of people during the months, during those 12 months that were using the plan was 6,000, but that's not necessarily,
That's
tell me what.
employees.
That's employees.
That's not the.
Not members.
Total dependents were about 9,000. I think we need to double check these numbers. I have a feeling that half families aren't calculated in here correctly. Because we
may
have
not
the
be.
2 spouses working for us.
Yeah.
So we only count them for purposes once because they're all put under one family. So I think half families, and that's about a 500 employee population.
Okay.
That should add more to those.
But
Okay.
but
And
even
then I
if-
also want to explain that August, we have everybody retire or leave at the end of the school year. So August is not a month that they're effective, yet they get effective, new hires are effective September 1st. So August will always be lower, but it's never been 5,900. So let us double check these numbers.
Yeah.
June, July, and August are all on the low side, but that's the summertime.
But if you're using an average, then the average should be the same thing in 2018 too. So when it's 6,500, assuming your number is 100% accurate, then that means you have the average. That means you have higher than 6,500 as well. So that means the overall numbers of month 1 through 12 were higher in 2018 than they were. So my point still remains the same, regardless of how we try to mumbo jumbo it a little bit. The average
We're not doing
enrollment.
that, we'll look into it.
No, I'm just saying though, just to make it sure we're clear what I'm asking. So, because I didn't even know what I was asking because they kept going back and forth. So the average employee enrollment in 2018-19 was 6,500. Let's just assume that's 100% correct. The new one's now 6,100. So the average is 400 employees less. Yet, the employee population, the total number of employees that we have on staff increased significantly from 2018 to 22. So it's not like we didn't have to close any schools. You know what I mean? We actually increased schools. So that number, the trend line should be
think it
increasing,
would.
not going down. There's an
Lauren,
inverse
you got all that
relationship.
history, right?
I do, and what I
Yep.
think is, it was calculated correctly 3 years ago, and then we messed something up in the calculation for the current year.
I mean, and
So let's
honestly,
go back and
it's
I really
okay
just
if
think
it's,
they've missed a half family on.
even if we discover that the average is down, that is an important data point for us to understand, because
Well, the PE.
like I care less about the fact, I don't know if it is or not. You're gonna do the calculations. I care less about whether or not it's less and whatever the cost is. I care more about why. And if the answer is because people went with another insurance, we need to know that because that will help us to make decisions about how we move forward.
And where to apply resources, to your point.
Right.
Correct. And then also calculating what the average total expenses are, because if the number is not being captured properly, then the number of expenses that we're expressing is different too. So I almost don't believe your data now. It's like, it's like
Well, the
corrupted data.
expenses
It's
are
like, I don't know-
correct. It's just
I don't know
matter
what to
of
believe.
divide by.
I know, but when you do the expenses by multiple people, when you go per employee, per patient, if it's like the denominator versus numerator.
Correct.
If the denominator is different, then you're gonna get a different answer. You know what I
Right.
mean?
Well,
No, it's a very
the
good
numbers
point,
up
and the
top
number
are-
would actually go down.
Absolutely. I'm not trying to be mean on purpose.
Yeah.
I'm just.
No, you're fine, you're
Yeah, I'm
fine.
not trying
But
to
I
be-
think the good news is that
I just
812
pay
will
attention.
go
I'm sorry,
down.
do my
if-
reading.
if
But
it-
these, the
that's
numbers on the
okay.
top are the medical claims. Those are all accurate. So when we talk about the average for the PEPM, the medical PEM, those are the ones that we need to get the number divided by and make sure those are accurate. But the numbers up top are the spend.
The actual total expenses.
Correct. Yeah, so the number will go down if that's correct.
Do we audit those total expenses then, to confirm that? Do we have like an audit report at the end of the year or something like that?
It's heavily audited.
By who? You know what I'm saying? Like, I mean, do we hire like an independent an auditor to come in there and say, okay, these were
The
the expenses,
financials?
and kind of go through there and confirm that that money truly is what it is?
It's all going through the finance department, and we're working on an audit for all the ether claims right now. Start auditing those claims.
Right, but some of these aren't just ether claims, some of them are fixed costs, like the cost of the healthcare center, because they also have a budget to actually buy equipment and things like that.
Sarah and our team are going over that type of a forensic look at the fixed costs and things like that right now.
So my enrollment number for May of '22, that's before everybody leaves, it's 6533. So there is something off between their numbers and my numbers.
So you'll know, on your health analysis that I reviewed, I take the total, which is 7,400, give or take, and I subtract the FSA.
Well, something I'll bring up. for the
That's
rest
where I
of
get my
FSA is
number.
not in, you need the opt-out.
To opt out.
That's what I just did.
No,
I
that's a
subtract the
workshop.
FSA.
That's an actual
FSA
motion,
should
a new
be-
business we'll talk
it's not
about,
even an
actual.
total
And like we do like.
In the
municipal funds audit.
7,422? That's where the error is.
Have coaches and stuff.
So let's
like
go
that,
through
and
these
charge them
numbers.
audits. I'm just trying to.
Yeah, we'll recreate.
Hey,
The good news
That'll
is
be
the
easy.
number goes
So
down.
to get the
Yeah,
accurate
our
enrollment number,
call
what's the
PEPM is
number?
going to go
Total?
down considerably.
Total minus
By
opt-out.
500.
That should be the total.
Correct.
Okay.
All right.
Glad the question was asked. That's
Yeah, I'll
good.
recreate the whole year.
We'll have a whole different picture. It'll be much better.
So right now, we're at 7,600 employees. So employees have gone up since you're 7,400.
Barry, do you want to go to page 23?
We had a intriguing month in September where we had 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 new entrants to the large claim cohort. And what we do here is we capture the people that have claims in excess of $200,000. At a previous meeting, it was we were queried, these first two, the 913,878, that's $1.8 million right there just from two people. And the question of concern is, especially from Lauren, was, are these things that are chronic and have been building up and we could have done something about, or are they acute? So we did an analysis of that, and anything below the first two is likely the claim impact creep over time, meaning in August, they might have been at 290,000 and then they had more claims and entered the plus 200,000 person group in September. But the top two were very acute in nature and did not have a significant history prior to those claims. But we had $3.8 million in large claims new to the group, which is not a good month, and it led to a $9,280,000 cost just in the month.
Those are the pink ones, right? The pink highlights are the new ones.
Are the new ones, yes, sir.
Oh, man, happens to be the most expensive one, too.
Right.
And so like I said, the top two were acute, so nothing could have been done to foresee those. And unfortunately, one of the people did pass away from that. So, but you can see down here the different conditions. You see a breast cancer, again, importance of mammograms,
Yeah.
Heart disease, cancer.
We got some, but that's what insurance is there for. But we do have some sick people.
That's what's wrong.
Somebody want to work the.
Oh, sorry.
You go to the next section we put together. We tried to look at how is the construction of your plan, and the two things we looked at is because we do direct contracts rather than renting a network from one of the major insurance companies or network companies. We use Evolutions, who develop direct contracts for us, and then the question becomes, how effective is our plan design? So on chart 25, and again, this is perhaps a little more dramatic if it's done in a PowerPoint with a reveal, but what we're showing here is how much was billed, how much was allowed, and this is tier 1 only, so this is our primary contracts. How many claims did we have and what kind of a discount did we receive? And in the red box at the bottom, it shows our discounts ranging anywhere from 72% to 81%, which is, in the commercial insurance world, nothing short of phenomenal. And significantly better than the discounts that some of the major carriers are selling on the street. So I would say that, and then slide 26, Carolyn, shows that our primary partners, Orlando Health, HCA, and Nemours, are the bulk of the hospital utilization, which is where we want it because that's where we have the deep discounts. And all others, including Advent and
Out of state.
is a relatively small percentage. And on slide 27, talking about the plan design, this shows what we call steerage, meaning you have a lower out-of-pocket cost for the employee if they go to tier 1 than if they go to tier 3. And of note, we still have people using the tier 3 hospitals, but relatively speaking, there's a dramatic difference. And more encouraging, perhaps, is the overall trend is down for tier 3 claims.
Now, they can still go to tier 3, they just have to pay a higher deductible or some more out of pocket.
Yeah, that's good.
So we're not gonna tell people you can't go to tier 3, we're just letting them know if you wanna save money, that's not the whole purpose. But, the point is, it's gonna be less of a hurt on their wallet if they go to a tier 1 versus tier 3.
Right, and we're contemplating some changes to that, but that's correct. For this year, certainly. The next section is just,
Yeah, you're contemplating changes to what specifically and what changes?
Here's some stuff that you guys heard in executive session.
Okay. Uh-huh, okay, thank you.
We're always, we don't rest on our laurels. We're trying to make this better as we go, and the data, we go where the data leads us. But if you look at the population health overall, it's important to recognize that 10% of your members, which is about 900 people, represents 63% of your total expense. And the top 10% have what's called a Milliman risk score of 2.4 and above. One is normative for just generally healthy people. And we've got a lot of people that are well above one. So as we look at our results and our efforts, it's important to recognize that we cannot hide from the underlying health drivers of the population we serve. The next slide. These are the people that have the highest number of open care gaps. And that means they have a situation going on where they should be taking steps and they are not. 37% of your membership has at least 9 gaps in care. And that could be anywhere from
Colonoscopy.
somebody getting a flu shot when they have comorbidities. Right. And 37% of our members, again, represent 52% of the open gaps in care that we're, and this is something we struggle with because you can't make people take care of themselves. We can try to come up with, and we're going to have a special session before the first of the year, is it, Ashley, or right after the first of the year? We're going to have a special session trying to address, we had a disease management program. And we had nurses that were calling out to people that had morbidity issues, chronic conditions. And we got, Lauren, what was it, 3%?
0.5% or
3% participation. No, I'm fine. And we're sitting there looking at the data going, well, you're okay to be fine, but you're not fine.
Folks that go to the health center have a totally different,
Well, and the good news
outcome.
is the risk profile of the people going to the health center is higher than your general population. And we like that because that means the health center is capturing some of the more chronic issues.
But they're more compliant, wouldn't you say, Kenneth?
Because we nag them.
Yeah.
And it's on the
So-
survey.
so the more
We're calling them
people-
too often.
More people that go to the health center, obviously, that's going to, improve these numbers. And for those that just want to, continue to not go to the health center, we're going to come up with a solution to make the numbers.
I think what might be interesting would be to look at the claims per member of the population that is a regular at the health center versus the general population. That's something we really ought to look at.
And some of the non-compliance it's minimal. It's not a big deal, and some of it is a very big deal.
Our employees don't typically do well with a stranger calling them on the phone, asking them about their health.
Yeah.
Most
Right.
of us are very leery and don't even want to answer a number that we don't recognize. That's why typically disease management has not been very popular with our employees.
And
Calling
America,
for
yeah.
Something new.
We're all sick of the phone calls. I mean, how many spam calls do you get a day?
Well, that's also indicative of a good reason why the health center is under independent management, because we cannot have the teacher population get the idea that management here at the school district has access to their health information.
And we
That'd be very dangerous.
There are ways to get to the schools, and so like that, sometimes I feel, I'm speaking as a past employee, that sometimes a disconnect, I feel, is that we're at the school and don't know about all these things, and it's not because of the outreach, because I was saying before when I met, I see Lauren Hagg's email all the time as a staff member, and I know, but to be able to take that time and maybe looking at the strategy to marketing to the schools and the employees where they're at, because they may not be able to come to Kissimmee or come to Louisiana and see all the great things actually that we had a chance to see, but and get input from there too, to say what they're using, what they not, what they wish they could see. But I think maybe having feeling like as an employee, you may have more input in some of that.
Ooh, she's right. I'm sorry.
I feel like we may have the same question for some reason. Have we ever like, have y'all ever attended like the professional development week before? Yeah?
The health center has not a professional development week, but we've gone to orientations with the health center.
Orientation for like individual,
Yeah.
new teacher orientation, but not for like the established veteran teachers when they come for
Yeah,
training.
we've done it a
week
couple
before. Is
times.
that a week before y'all?
Did you ever come to any of the?
I remember you had me go to some big ones, I just don't know
Is
what
that-
They came to the wellness champion meetings. Our department goes to a lot of those. But again, it's few and far between and, with everything else that's going on in professional development day. We do have tables set up at all those events, so the employees can come out and talk to us. We go to transportation, even recruitment events to get them to come out and talk to us. But you guys approved a job description for a benefit educator so that we can send that one out. We just haven't hired anybody yet to go out to all the schools and start educating on all
Yeah.
the different benefits.
I think though, I mean, I didn't work at the district, but like even when I was working corporate, like there was always some like person like on Thursdays like talking to us like, did you know that open
Yeah.
enrollment's coming up? Yes,
Right.
I know.
And we do have health champions at all the schools, so they have a job description that they have to do at their schools, different wellness events. They group for our 5K and.
Smoothie bike.
Sorry?
Smoothie bike.
Yeah.
Smoothie bite.
Fun.
Yeah.
That's cute.
And then we go to
Yeah,
Judy's
a
school,
comment.
she makes sure everybody come out for the smoothie bike and ride the bike for it.
But to Ms. Boo's point, though, what she brought up to me that was kind of interesting, I'm a little bit older. I'm the one that thought of the idea of having health center in the beginning. And one of the reasons why I was rejected, because they said that there's a certain mile radius where people live that would attend there. I would like to see that kind of map of all the people that are attending versus not attending. And I think that the distance from the health clinic to where they ultimately live, because they don't always live where they go to school at. They may go to school or teach at Celebration, but they may live in St. Cloud or whatever, or Poinciana.
I'm speaking of district vibes, we're really rural, where we're at.
Yes.
Anything-
So that's what I'm curious to see too. So if we can, like, on your regular quarterly updates, put there, okay, this is the total map of people where they live compared to the ones that are at the clinic versus the employees that are
We
not.
have to
We
get
did a
the
heat map
of
of people.
people that are attending.
We haven't done a full heat map that I've seen. And I've also wanted it to be by a work location, because some of them might live in Harmony.
Yeah, have to.
You can do both.
Gateway, so.
A work,
That's very powerful too.
Because I have
At
a
least for
feeling
the
that location
employee.
is going to be a
They're going to be
significant
in
factor.
one location at some point during the day.
Well, and one challenge we ultimately will need to address is geographic access. It's such a huge footprint. And Poinciana, I don't know if it means building up Poinciana or if it means engaging with primary care physicians at different locations so people can access the primary care. And of course, they're used to traveling for specialist care. Page 32, again, just some things that we're looking at. We're working closely with Sarah and Mr. Kruppenbacher on the footprint is charity care, but for folks that are of modest means and ultimately do have an out-of-pocket, whether it's $2,000, $2,500 or whatever, especially if they go to a nonprofit hospital, there are programs set up to waive or forgive their out-of-pocket. And it's not overly complicated, it's a little time-consuming, but we're looking at the possibility of hiring a resource for those teachers and bus drivers and overall
Yeah.
staff to be able to have a resource to help them pursue a situation where they might get a $2,500 out-of-pocket waived by the hospital. So we're looking at that.
in order for hospitals to claim the nonprofit status, they have to give so much away in charity care. In order to qualify for charity care, it's all based on your income, based on the federal poverty level. So we believe that a certain population may qualify for that. $4 is a nonprofit that will help members fill out the forms, apply to the hospital. They know the rules of the hospital and help them has to be done within so many months of the claim happening. So, but educating people that even though the school board paid the majority of the cost of the hospitalization, their per percent may be forgiven because of the tax advantages that the hospital receives. They have to provide charity
Right,
care.
yeah, the program is there in the environment, but if your people don't know about it or perceive it as too complicated to pursue, we're not taking full advantage of a government or tax-based situation.
And the nonprofit hospitals are not advertising this as
Oh,
much as they
no,
do,
it's
as much
way-
as they do their
it's
emergency
way
rooms.
buried in there. It's way buried in there. And $4 is the organization that helps bring awareness to the hospital that they do have this program and they do have to offer it to maintain their nonprofit status.
And Mr. Melendez, to your point, we're very concerned about diabetes for a group like this. And it's not just the diabetes, but most of the folks with diabetes have comorbidities. So we have a call set up tomorrow with a company called Twin Health, which is a diabetes monitoring and tracking program. Kenneth has already reviewed a company called Verta. There's a new technology that involves infusion therapy for diabetics to reduce insulin resistance. I'm excited about that because I've been tracking it for about a year. And if we could get infusion capability into the health center and manage that process ourselves. And what it means is instead of taking $400 a month of Jardiance or Januvia or Trulicity every month, people would have an hour and a half's infusion once every 6 to 8 weeks and have dramatic impact on their A1C and literally reversing the diabetic issues.
But also it's that lifestyle. So if you didn't have to take injections or be insulin dependent, things like that, and you have the freedom to not have to feed the insulin or things like that, it can change someone's life. Again, so we want to be innovative on the cutting edge of things, be very cost conscious. Your staff works so hard for 40 years and giving their time, or 50 years, whatever long. We want to make sure that they're around for retirement and then can enjoy their retirement. So getting them to have a quality of life that is freeing for them.
And another thing that we're also looking at is your premature rates. And one of the things
Premature
that
babies.
we at Rosen, we have a very, very high risk and high premature rate for that population. So we're going to be looking at yours too, because we established a contract for another diagnostic test for the OBGYNs to run if it's appropriate. So I'm going to be looking at your numbers and just seeing, does it make sense to have it available as a tool? Because if that tool is able to provide that provider with risk for that individual, you as a district will save, because then we can intervene faster with meds and things like that to keep that baby in the oven until an appropriate time.
I have 3 babies that were all preterm on district insurance, so I'm sure we could have saved money.
Well, there's 3 right there.
Yeah.
So this
Exactly.
test is done, it's a blood test that's done at a certain week, I believe it's
19.
19 weeks, and it will tell if the baby will be born premature.
Now, we do,
What's it looking for?
so they're looking for various proteins in the blood, but we know of high risk. You know,
Yeah,
if
high
you're
risk is, high
HIV,
risk. These are
hypertension.
non-high risks that can be identified as premature.
But you can't stop the baby from being born, though, right?
No, but then
If it's gonna be preemie, it's gonna be
We're gonna
like-
slow it
then the
down.
OBGYN and the mom work
High-risk
together to slow that
medication
down.
things,
So our goal is to slow it down. The closer we can get to like the 35 weeks, the better. But there's deliveries at 24, 25 weeks, and you're talking about $1 million.
Mine
is
were
what you
29
pay.
weekers, 48
29.
days in the NICU, yeah.
Do you remember with the cost?
Really?
Over $1 million for
Right there.
sure, yeah.
Times
Yeah.
3.
Wow.
So if we can identify it earlier, then we can give the meds and the appropriate high-risk care to keep that baby in the oven as long as we possibly can, which will ultimately save the district, well, save the child's life, save the mom's life, and save the district the money.
There's also, I mean, I don't know, but I'm sure there's also like some additional like health, like, that the baby might experience. if
Oh, yeah,
they're
there's definitely
preemies as
after,
well.
yeah, with my
Yeah, so
girls, we
that's-
had
it's
lots
not
of follow-up
just,
care too.
you know,
Yeah, it's just not the delivery and not the first, yes, you're.
It's like a lifetime
Yeah,
of
if the baby's
concerns.
born, so much premature, it's a lifetime.
Yeah.
While we're talking about what things we're looking at, we're also pursuing several genomic solutions. There's a genomic test, which is basically looking at the DNA strands to determine the effectiveness of chemotherapy for breast cancer. Something like 70%, 75% of all breast cancer chemotherapy is ineffective
Yeah.
and just ruins your day.
So if you could imagine having breast cancer, first of all, and then receiving toxic medicine that you didn't need.
Yeah.
So this one test will tell you whether you're receptive to chemotherapy, whether that breast cancer will be receptive to chemotherapy or not.
There's also genomic opportunities on the horizon to determine the relative effectiveness of pharmaceuticals.
Yeah.
My daughter, I just found out, has very low folates. And
Goodness space just.
what that means, apparently, in street speak, is that the effectiveness of most of the medicine she's taking is diminished by 80%. So now they're gonna put her on something to increase her B12 folate that will help her to metabolize and utilize the other prescriptions. So there's a lot going on, and why don't you take a minute and touch on GWell and what we're doing there?
When we're ready.
Oh, okay.
So what you have in front of you in this nice bound copy, we gave you one last year for the plan year 2020 to 21. This is a summary of the 21 to 22 plan year. So it's an executive summary. In the beginning of the book, the first one is the advisor's commentary. So we cite different things on different pages that you might want to look at.
That's just kind of a roadmap.
Yeah, page 1 through 5 are Cliff Notes.
Yeah.
Yeah.
And then after those pages, our data analyst also gave his commentary on the different data points some things that he found out. And then there's a whole, 100-page report for you on the different things comparing last year to this year.
I'm gonna be reading this by the fireplace
Yeah.
over break. I'm excited.
Here's right here, your top, on page 3, top 20 diagnoses.
Yeah.
Yep.
Procedure codes, top spending terms.
Correct.
Oh, this is informative.
Yeah, it's really, well, we call it exciting.
It is.
We'll wait for
We're very
your.
nerdy with this stuff, but.
I'm already nerding out on it. What are you talking about? Yeah. I'm not gonna read it now.
No.
For your reading pleasure.
Is there anything that stands out? I mean, we can, like you said, we can read it later, but is there anything like significant, like, what Ms. Castillo's favorite word is the delta, which I like that word too. You know what I mean, is there anything like, this is gonna be significantly different than what we.
One thing that we noticed this year is ER visits are down, and the people that are going to the ER, it was appropriate care. So before, we had a lot of abuse of the ER. They didn't know where to go, so they went to the ER. So we're seeing that it's not well, they didn't know where to go. They're going, because that was the appropriate place to go.
Now, is it going to the urgent care now? Like, what's the difference? I mean, where are they going to get it?
So-
Telehealth is going way up.
I think that was related to COVID or just actual healthcare issues as well.
It's always been a large utilization. This is a great number.
I know that's, oh, sorry, go ahead.
To answer his question, we have Orlando Health televisits, at no cost to the employee, and that has been very popular for employees because you can just be anywhere. I made Dr. Pace come and do it the other day. You could be anywhere and do a little visit. They send the medication over to your preferred pharmacy, and it's at no cost.
And is it just educating them on knowing to do that versus showing up at an ER?
We have like a whole, like, where to go, like, kind of, like restaurant with $1 up to $5. So it's kind of sense of urgency at one Band-Aid maybe, which would be televisit, and then going up to the ER. So we've created those. I do want to point out about the televisit with Orlando Health. We've been using it for 3 years, and Orlando Health is such a wonderful partner with us. They can't seem to find a way to bill us for that telehealth, so we have not paid at all for any telehealth.
Are we gonna pay at
So
some point?
I
You're
have
gonna
had
send us like
numerous
a-
meetings, so I have always said to them, just so you know, we are not going backwards.
Okay.
So we are not asking for that claim back, and they have
That's what you were
nodded
looking
to that.
for, right?
Like,
So,
what does this do?
We legally advise you, do not give them the answer to that.
So I just said we are not going backwards, we're only going forward. We'll help you with file feed and connections, whatever help you need to help us process claims. I'm here to help you. And
Now we've just said that publicly.
Ms.
they are,
Castillo,
yeah.
Yeah.
An important number to look at, remember, we were talking about mental health?
Yeah.
There's not a page number on here, but you can see that the claims on the mental health are up across the district.
So actually, to that point, which connects to Mr. Melendez's point, and actually to everything, let's just connect the dots. So the reason, fellow board members, the reason why the ER visits are low is because there was an intentional strategy for that. Like, we saw them up, we said fix it, and he did. So to that point, and to extend to Mr. Melendez's point, what do you think we need to be focusing on for the next year? I mean, we have a strategic plan conversation coming up, and I think it's important for us to include the health plan in general. I'm not sure where that would be.
Yeah, it's like a
possibly
subset. you know,
Under
Goal 3,
Staff
fiscal
budget?
responsibility.
goal 3, fiscal. But I also feel like we'll talk about it later. It should also be
Yeah.
like under recruiting and like,
Recruitment.
And we've had it in
Yeah.
places.
Yeah.
In the end, what we found was that the conversations were deeper when it was with
Yeah.
goal 3, but that doesn't mean that we aren't discussing it as a part of goal 2.
yeah, we can still have activities. What I would request is, as we gear up for that really important conversation, if you can identify what are some things we can actually move the needle for, and how do we embed that into our strategic plan, so we're not just saying, oh, cool, here are things that we're gonna change, but like, how does that relate to our strategy and also like the total wellness of our employees?
I think at a high level, we have an issue with chronic conditions. We have 600 people that have 3 or more chronic conditions, comorbidities. Diabetes, I think, needs to be a major emphasis, and I think at some point in time in the next 4 months, we're going to be bringing forth a cancer concierge service.
We don't need the answer right now. Just, I appreciate you.
But that's what I said.
Yeah.
It's
You want us to
it's
think
at a high
about it
level.
and say for the next
He already,
year.
he's like, oh, I got
you know,
this, Carl, let me
yeah.
tell you.
And now we're not just, hey, there's a new magic, there's a new rabbit
Diabetes.
here, there's a rabbit there. I'm
Well,
like,
some
hey,
of it goes back to, I think, page 29 and 32, though, is the risk distribution of costs and the quality distribution.
Yeah.
You know, like, if we can help change the needle on that.
Well, we've already been working a lot with quality in that our navigation partner we work with, Century Health, formerly known as MAP, when members are engaged with those nurses there, the nurses are doing research behind the scenes on licensing, board certified, medical malpractice, their outcomes, their complication rate, their volume rate. So these are things that you could never find on your own. You don't look on Google for this kind of information. So when they make recommendations to the members, they know that that is the doctor or the providers who are best in class. Because there's known that when you go to the best provider, it just so happens that it actually costs the plan less money.
Oh, yeah.
Because less complication rate, things like that, they do less, they know the cost of the procedures are actually less. So it definitely helps us when the members do engage with MAP, and they are using it a lot.
Yeah, they use MAP a lot, and that actually goes back also to what we did with steerage. Many of our members, because they want to save the deductible, will call MAP on their way to the ER. So
Yeah.
MAP can triage them on the phone and say, no, this is not something that you should go to the ER, go to this urgent care instead.
Yeah.
Or you can wait till tomorrow and go see your OT or whatnot. That whole engagement, our employees just absolutely adore working with the MAPers. It's been very good for us.
Yeah, I mean, if you can just give us a heads up, like, what do you think? I mean, I love some of
I
the
know
stuff that's coming out.
another
but-
thing that we hear, not a lot, we hear about a few, is social services from employees. that there are employees that tell us that they can't afford even their copay to doctors, and that we often are asked for resources, or they can't afford their deductible. So we refer them to church groups and United
We
Way.
partner with the
and-
Education Foundation and make that part of the plan. You know, the foundation has like a kids closet, they have scholarships, they
I
have.
don't know if that's like their focus, though.
Oh, yeah, it's a nonprofit to help the employees.
Yeah, so I don't know where to refer.
They never thought about doing that
Yeah.
before. I'm talking about like, neither was Kids Closet until we had a bunch of poor people in Celebration that couldn't afford to have clothes. And then we implemented school uniforms. So then that's why we started implementing it. They didn't have the Kids Closet before, so.
Yeah,
Man,
so
if
if we
that's
had
something I'm
something that we
hearing,
could
that a lot of
refer
people
them
can't
to,
afford it, you know,
and
they can do
you feel,
something.
I mean, I've been tempted just to pull out my credit card and help them. But if their child had a field trip and that was their copay for their
Yeah.
prescription drug,
Yeah.
then we don't want them not having their prescription drug. And so we're kind of, that's a rock and a hard place sometimes for us.
So I'm just trying to synthesize this into like a goal that we can consider.
Social services.
Partnering with nonprofits for social outreach
Or
or
if there's like
something
a,
like
I know at Rosen, we have social workers on staff that are there and provide resources to employees that are
Yeah, 'cause
just
I like the idea of even like the foundation, even having like an annual fundraiser.
Yeah.
And saying, hey, we're gonna raise money, get together your business partners and put into like a pot, kind of like a mini grant. You know what I
Yeah.
mean? So an employee has a problem, they go there and say, hey, can you help me out with the deductible? They have somebody that kind of filters
Yeah.
out and says, okay, boom, here's $250 for like a visit or something like that.
Yeah.
You know, kind of like.
But it may make, like at Rosen, we have a, like, on staff, as you said, you know, social services person that is familiar with all the tools that are
In the
available,
area.
right? And
Food
can go,
banks
you
and
need to
things
go
like
here,
that.
you need to go here, you need to go here.
And we have gotten the help from special programs. We've had a couple of employees that come to our health center that their house was completely lost in a fire. Special programs is helping out.
Okay.
I think it's getting her at the table with this, there's so many partners in the community that reach out, and it's not advertised, it's just for dignity purposes and things
Yeah.
like that too, so.
Because I just learned that, because I thought Leslie was just the students, I didn't know Leslie was
No.
supporting staff too.
Yeah.
Yes.
Well, if you have a cafeteria worker who has just got diagnosed with a big condition to meet their, we can talk about charitable care at a hospital, but what about their prescriptions and things like that? I'm sure Eric would probably donate it or something, but when they call us or email us, it breaks my heart.
So she just brought up Eric. The EA came to the health center last week for licensing. Soft opening is next week, starting Monday. That means that he is moving in over the holiday break for our employees, and we hope to advertise it out to the full population in January, so the pharmacy will be open sometime in January.
Yeah.
Yeah, so I think that's the right direction to do that. Just ask Leslie first before we go to foundation, so we can see what already exists.
I'm sure Dr. Hayes.
And maybe the foundation can help.
Too.
I'm not sure that it's the foundation's primary role and responsibility. They've really focused their attention back on scholarships for kids as opposed to other kinds of programming, other than like the little things that they do, like a gift for teaching and the Take Stock program. But yes, I can connect us with Leslie's team and special programs. And then also, we have our social workers on staff. It may be a matter of helping to get information into EAP's hands, but we'll certainly kind of take that back as something that we can look toward.
Right.
Thank you.
So the Oscar music telling us. it's over.
Yes.
That's fine. Awesome. What other questions do we have, team? Thank you.
Thank you.
Thank you.
Yeah, appreciate your all's work, and please let us know what the change is in that chart.
We will redo it and then send it
Yeah.
back out for distribution.
Okay, thank you so much. Thank you.
Well, it's a truly pleasure serving you all. We're here, we're all on the same side of the table to help your population and help the school board. So for better health, financially, we all have, our goals are aligned.
Yeah.
And we're getting there. It's a big population to get to move, and hopefully we'll get more and more engagement with our programs.
Yeah, thank you so
Thank
much.
you.
Merry Christmas.
Merry Christmas.
Merry Christmas.
Yeah, we don't even, it's 5:30, it's a regular board meeting, it's not another workshop.
See you.
I'm trying to get him to keep it.